everybody. I thank the organizing committee and Professor Chernak for inviting me to talk here. He asked me basically to talk about all the interventional minimal invasive modalities, but my talk will be followed by Professor Kessler, which is an expert on RFA, and I will be talking only on transarterial techniques, chemoembolization and radioembolization. I will try to address the questions of what evidence we have and show you some examples of different scenarios where TACE can be used. In a nutshell, what is TACE? We are delivering a mixture of different agents transarterially via catheters into the hepatic artery. Usually, what is called classic TACE is adriamycin, which comes in powder, is dissolved in contrast material, and then suspended in lipiodol. And then you get the nice red color on the syringes, which everybody is really enthusiastic to see for the first time. This is the mixture of both drugs. This is followed, not always, by an embolizing agent, usually gel foam, pledgets. Usually we cut them to 1 millimeter cubes, but sometimes by other embolic agents such as polyvinyl alcohol. A typical patient, I mean, I wish this was a typical patient, but you can see on the left a hypervascular mass on the diagnostic image. On the right, followed by a microcatheter insertion to the vessels feeding the tumor with the adequate arterial blush, which is the point where the drug mixture is being injected from. This is a result of this patient followed with a 1-month CT. The first sequence is a non-contrast CT where we want to see the uptake of the lipiodol. And this is followed by an arterial phase CT, and the difference between the two scans shows us if there is some residual tumor to treat. But this is really a utopic patient. Unfortunately, not all of them are like this. So even though TACE was first reported in the late 80s, 2002 was a landmark year for TACE and the people who are using it. In this year, 2 papers were published, one from Hong Kong and the other from Barcelona, and they were the first randomized controlled trials showing that there is some advantage to TACE on a significant level. In the Hong Kong trial, 80 patients were recruited and divided to TACE receiving group with cisplatin and lipiodol, followed by gelatin sponge particles, and the other group got only symptomatic treatment. TACE was repeated, as always, by 2 to 3 months intervals, and there was 4.5 course treatment per patient. TACE resulted in marked tumor response with better survival, significantly in the embolization group, as you can see here. The other paper came from the group of Lovet from Barcelona, and here they had a 3-arm study dividing 112 patients to a group of TACE compared to bland embolization without the chemotherapeutic agent, and the third group for control. Again, the TACE group had an advantage with lower rates of portal invasion in the follow-up studies compared to conservative treatment. Like I said, there's some discrepancies about different protocols. What is the anti-tumoral effect of TACE? Is it accomplished through the occlusion of the feeding artery, namely causing hypoxia and ischemia, or the local chemotherapeutic effect of the adriamycin or the other drugs? How about occlusion-related hypoxia and chemotherapy? What did they do to neovascularization? Is it good or bad? We don't know. Currently, there are 3 RCTs comparing TACE with bland embolization, and only one, the one from Barcelona, showed that TACE is advantageous to bland embolization. A meta-analysis in 2007 didn't show any difference between the 2 techniques. Since no 2 ACC patients are alike, there are also a lot of protocols all over the world. I mean, You can read the papers. I don't think you will be able to find two papers that are employing really the same protocol. What is the interval between embolizing sessions? We don't know. There are no controlled studies to check that. Usually what most people would do would schedule the patients on fixed schedules, or alternatively follow them up with imaging and then decide based on arterial enhancement whether the patient is going to have another procedure or not. Multiple agents are used: doxorubicin and cisplatin, mitomycin, also epirubicin. Sometimes the combination of these drugs is used. And also embolic agents, mostly gel foam, but sometimes some people will use polyvinyl alcohol, which is a permanent embolic agent. Another issue is that HCC has different phases. This patient on the top has a segment 6 lesion here, which is very hard to see. And on angiography, there's also some arterial portal shunting as a proof of portal macrovascular invasion. This is the CT following the chemoembolization procedure, showing very, very scarce uptake of lipiodol. The second patient is a dream patient for me, where you see CT scan, a pre-procedure CT scan, you see the exact segment 2 vessel supplying the tumor, which has a very nice and localized blush. What does this mean? This means that I can go in selectively to this vessel and inject the mixture only to the tumor, because I don't want to damage the already damaged liver. This is the follow-up CT. You can see, compared to the image on the top, how dense the lipiodol is concentrated. It's a very good prognostic factor as well. This slide, familiar to everybody. I don't think the ACC treatment talk can go without presenting this. Helps us for selecting patients. Mostly, of course, the Barcelona clinic algorithm. Most patients, nobody is debating that, are from the intermediate group, which are allotted to chemoembolization. But we want to extend. The stage A group is basically patients who are intended for curative treatment as well, but sometimes TACE can be helpful there, for example in RF procedures where the lesion is unreachable. On the right, how about advanced stage C patients? Are we pushing the limit? Yes, we can do TACE for large tumors. We can do TACE to portal invasion, which 10 years ago was considered to be a contraindication, not anymore. We have treated 97 patients in the last 9 years with 183 procedures. Our protocol is doxorubicin powder dissolved in contrast, suspended with lipiodol, followed with gel foam or PVA if there's no portal invasion and if the liver function allows us. We treat the lesion, segment, or lobar, depending on the CT and angiographic image. How about different scenarios? This is a patient, like I said, which falls to the group A in the BCLC classification. He had a 3.2 lesion on the dome of the liver, treated by RF. The follow-up CT shows some arterial enhancement. So this is where we come in and can perform TACE as a completion procedure to treat the lesion. You can see the tidal uptake there. This can go the other way as well. We can do TACE before RF. We haven't done it, but people are reporting instances and using the logic that TACE can reduce blood flow, therefore enhance the effects of RF by letting the blood flow down, helping the RF perform better by getting a better RF efficacy. This is not really proven in the literature, but there are some papers that are advocating this. I don't think anybody, like our previous speaker talk, anybody will doubt that patient on a transplant list who has a lesion amenable to chemoembolization should have that. This is a group of patients that undergo TACE when they're on the list. But another group is patients who are also waiting for resection, either as a definitive treatment or is a group of patients who are treated initially by TACE and then are offered resection as salvage treatment. This is a 68-year-old patient with NASH cirrhosis who has a segment 6 HCC with portal vein thrombus. You can see that in the image in the middle, extending to the main portal vein almost, with the rising of alpha fetoprotein to 5,000 units after 2 TACE sessions. This patient went on to have right hepatectomy. Downstaging of unresectable HCC by TACE was addressed by Chinese writers a lot, and this group reported downgrading the tumor in 25 of 52 patients, and then offering them resection, and with a 49 months survival after surgery, of course. Sorafenib is a newcomer in the HCC treatment. It has an anti-angiogenic activity, but we know that TACE can stimulate angiogenic growth by VEGF secretion. So we can coordinate treatment of sorafenib in order to prevent from VEGF promoting cell and tumor growth with TACE. And after performing chemoembolization, for example, we can place the 3 weeks after the procedure, when there's the peak of angiogenesis, place the patient on sorafenib in order to address that. How about the stage C group patients, large tumors? This is a 11 centimeter tumor, very vascular, which means that it's easy to treat, even though it's very large. And you can see on the right very dense uptake of thiol, which is a very good prognostic sign, as well as some necrotic areas. We can repeat that as many times as we can, or the patient allows us. So trying to push the limit further to treat more patients. Also, we can see this group that treated 30 patients with a mean age of 70 with both hepatitis C and B virus related HCC with a 7.7 centimeter tumor, and treated these patients with up to 13 sessions and had three infectious complications, which is the main complication when you see when you follow this route. In large tumors, what you have to look for is extrahepatic supply. Often, if you do an angiogram on a large tumor, you will not see all of it because some recruitment of blood from the surrounding vessels. And on the left, in descending order, you can see the most prominent vessel supplying tumors in the periphery of the liver, as you can see on the image below, on a tumor in the liver dome that also is invading the capsula and abutting the diaphragm. So this patient was also treated with inferior phrenic embolization. Another thrilling topic is the portal vein thrombosis patients. A lot of literature is based on this, whether these patients can be treated safely and in what modalities. This is a beautiful image of the tumor on the apex here, but you can see the extension of lipiodol into the tumor thrombus into the portal vein in a fashion called string sign. And the follow-up CT is also concordant with this. You can see the lipiodol going down into the portal vein very efficiently. So portal vein invasion is by no means a contraindication anymore. This was also checked in a study that compared patients who had portal vein thrombosis to those who didn't, and found that the most important thing was whether they were responders or non-responders. If they responded, the difference between their survival rates wasn't very significant. If there was non-responders, then it didn't matter if they had portal vein thrombosis or not. Patients in high risk, not necessarily with portal vein thrombosis. This is a collection of patients from the East Coast, from 3 or 4 centers, had compensated liver functions with bilirubin levels even above 3 milligram per deciliter, and low albumin levels. Some of them had also portal obstruction. They were be able to treat them with chemoembolization safely with minimal extended risk beyond patients who are not in high risk. What matters is if you can treat them as close as possible to the tumor and avoiding injection to the unhealthy liver. That's the most important thing. So this slide is becoming shorter as the years go by, and it's very hard to deny patients TACE. I think nowadays elevated bilirubins above 3 are not very good candidates unless you can really selectively inject to the tumor. Biliary obstruction, which is untreated, also has very high complication rates, so it's a scenario where TACE is not very good. This patient has a very dense uptake of etarol, but also, even though he had no high-risk biliary obstruction, had the complication of liver abscess posterior to the tumor in the blood supply area. He was treated by antibiotics and drainage, and he recovered from this. This patient had the previous case of embolization. You can see the etarol uptake up there. This is the second case for treating this lesion because there was some arterial enhancement. And when he came for the third time, we saw that there was arterial thrombosis, probably secondary to arterial dissection, and we couldn't go in there anymore. You might hear more and more about drug-eluting beads. This is not yttrium yet, okay? I'm talking about drug-eluting beads, beads that are loaded with adriamycin. It's called precision TACE. There was a study going on in Europe, and they recruited patients for this study in order to check if it's safer and if it's feasible to perform in high-risk patients. So this group of patients had reduction in liver complications related to adriamycin, as depicted by AST and ALT levels, which were lower. And there were significantly better tumor response and disease control for more advanced patients. So they're offering a precision TACE for patients who are relatively in high risk. How about radioembolization, the final topic of my talk? You will hear more and more about yttrium-90. This is a pure beta emitter with a 64-hour half-life. What we do is we get in the container here beads that are loaded with yttrium, and then in a transarterial fashion we inject the affected area of the liver. There are two agents currently available. One is Serospheres, which is available in Israel. Terospheres is not here yet, but it's available in the States. The difference are that Serospheres are from resin, and they come from Australia. Terospheres come from Canada, and they're from glass. The sizes of the beads are more or less the same. And Terospheres is much more, I think, helpful in treating patients with cirrhosis and some degrees of portal hypertension because it has a lesser embolic effect because there are less spheres per vial, whereas Serospheres are 40 to 80 million beads per vial have also embolic effect, and I think in HCC patients it's not a very good idea to use them. But This is a case from our hospital. I have to admit, this is a case with a colorectal metastasis. We haven't employed yttrium in HCC patients yet. I'm not very enthusiastic so far, but just to show you what the technique is all about. You have to do a pre-operative, pre-procedural angiogram in order to prepare the patient for this technique. You have to do, in this patient there's a replaced right hepatic artery, but you see the hypervascular masses on the right and then on the left lobe. What you have to do prevent gastrointestinal complications is to embolize the vessels connecting the liver to the stomach and duodenum. And this is the GDA, embolized with coils, and then followed by right gastric artery here, embolized by coils. Patient goes home, comes back after 1 week for the real thing. And then we admit him again and go in selectively as we can, inject the yttrium into the right, and if it's bilobar disease, go out and go back to the left hepatic artery. Not because the right is replaced. In normal anatomy, we would do the same thing. It's a very cumbersome technique. The procedures are very long, and it also needs the cooperation of all kinds of people in the hospital that usually you don't work with, like radioisotopes or radiation protection people. And what is the experience so far with the yttrium? Sangro in Europe collected data from 8 European centers in 325 patients with BCLC, C of about half of the patient, and a quarter were BCLC-B. And they achieved survival with reembolization, including in advanced disease. But what the most important thing was the not complication, but side effect risks. So like after radioembolization, the main thing is fatigue, and it's a little different than post-embolization syndrome we meet after TACE, where it's very dramatic and the patients are with fever and throwing up and have bad degrees of nausea. So it's a little safer. So the problem is that even though this is very cumbersome to use, there is no survival advantage compared to TACE in radioembolization in these 2 studies that were presented in Europe and also in the Far East. Head-to-head with TACE, the biggest collection of patients is from Chicago, from the group of Riyad Salem. This is not a controlled study. In order to do that, they will need to recruit about 1,000 patients. So the main thing that they were coming up with is that similar survival times, and no advantage for radioembolization as far as that's concerned, but better tolerance by patients. Okay, with that, I will pass the baton to Professor Kessler to talk about radiofrequency ablation.